Primary retrieval in Sri Lanka encompasses a vital network of emergency medical services. From accident scenes to critical medical situations, these responders navigate diverse terrains to provide swift and skilled assistance. Let's explore the intricacies of primary retrieval in Sri Lanka, where timely interventions and compassionate care converge to bridge the crucial gap between emergency incidents and specialized medical attention. I have the privilege in inviting consultant emergency physicians, Dr. Indika Lanarol and Dr. J.K. Vairamadushankar to chair the session.
Welcome you all. It's the final session of the first day of the very first national conference Sri Lanka. So the topic today is primary trauma retrieval. As you all know, world over, retrieval medicine plays a huge part when it comes to the successful trauma management. It's a big topic, has made world advances in developed countries. It's starting to see that Sri Lanka has taken steps, is taking steps actually, to be on par with the developed countries. To grace the occasion, we have a prominent panel of speakers. Our first speaker is Dr. Kumar Puruli, a product of Jaffna University, who has obtained his fellowship in Obstetrician College of Emergency Medicine, has worked as a retrieval and emergency consultant since 2012. And he has special interest in pediatrics and trauma. His topic would be primary retrieval systems in developed countries. Over to you, Doctor.
Good evening all. It's a pleasure to be here. It's not usual to see so many people in the conference in this time of the day, but thanks for being here. So my name is Kumar, so I'm trying to share my experience in the retrieval system in Australia. That's me in my younger days. Before starting that, I was so impressed with the way the sim lab was run. It's really happy to see how the ED approach to trauma is progressing. And then even more impressed with the last presenter of this presentation, the thoracotomy which was done at the ED. Now, retrieval, in a sense, you might say it is a glorified version of ambulance transport. That's the basic version. The extreme version is that you can take your ED right at the scene. So we can do the scenario which was done in the sim lab, in the scene. And you can also sometimes do one of these thoracotomy if needed at the scene. So you basically try to get the ED or the ICU care in the retrieval in the scene. So a bit of a history. Usually initial patient transport, commenced in Australia way back in 1928. That's when the Royal Air Force was involved. In 1942, they had the first rota patient transfer. These are all patient transfer, not necessarily retrieval. And the major step in all these things was 1976, where they had the first batch of paramedics. Why retrieval is so popular in Australia? Just purely because of the magnanimity of the place. About 8 million square meters. Most of the people live around the coastal areas. Doesn't mean that they don't live inside. The services are way far in between. So in order to keep the people where they live, they need to be they're compelled to give medical facilities. Hence patient transport and retrieval. Now, retrieval involves one on-site clinical management or resuscitation, safe transport along with clinical stabilization, and then communication between the site and the receiving hospitals. All these components are involved in retrieval medicine. So we used to call retrieval as primary and secondary. Primary involves it's about taking the patient from the scene. Most of the time it's trauma related. It might be MBA, from the accident side. It could be a side where the patient has fallen off. But it could be medical as well, where you go as an MBA to find out, the real issue is the cardiac arrest, where you have to perform the CPR and ALS and all those things. Most of the time it's trauma related. Secondary is interfacility transfer, plus. So, in essence, although you've got the skills and the tools to play with at the scene, movement has always got to be at the back of the mind of pre-hospital. You have to realize you're not going to, the treatment still needs to happen in the hospital. You can't get the theatre down there. The treatment, the ultimate treatment happens in the hospital. So movement is always going to be at the back of the mind. You have always got to think, got to know these patients. So, in that terms, we can say some of these patients, what we do is scoop and run. Right? You see a patient at the scene, you do a rapid assessment, and then you say you only need minimal intervention, you take him and run, and you make sure that the transport will be okay, you'll be there in the hospital with a stable patient. That's scoop and run. Versus, sometimes you can't do that. The patient is so unstable, you have to involve, you have to resuscitate the guy and stabilize the guy and to take him alive to a place where they can do the treatment. Organization-wise, how it's organized there, it's a state-wide thing. Every state has got its own retrieval team. There'll be an incident command center where it's been manned by 2 retrieval physicians. They will have access to the calls will come from the ambulance services, police, or the hospital, little hospitals to do mainly secondary retrievals. What the incident control have is they'll have access to all the ICU beds. They know exactly how many ICU beds are available in a certain hospital in a certain region. And they also know the assets available, assets in terms of ambulances, helicopters or planes, or crews. You can just man them. So they'll have an idea of who is there, what's available. And then, depending on the call, depending on the clinical assessment, they'll allocate the assets. What they also do is give advice. If you're in trouble, if you're in a medical hospital, they'll give advice as to how to manage this patient. And the other thing is they'll communicate between the team and the receiving hospital, so you have a smooth transfer. Skills and the team. It is an expensive exercise. You've got a medical officer. Usually they are consultant-based nowadays. They've moved on to consultant-based retrieval. So just imagine you're putting a consultant on the back of the ambulance. Along with the senior paramedics who will be ICU trained, or sometimes it will be an intensive care nurse. So the team is very efficient, and you've got to have some more skills to do that. The first thing we expect, the medical skills. They should be able to manage major traumas, high-risk obstetric cases, and critical care of adults and pediatrics. Most of the time it's done by emergency physicians, sometimes the intensivists, sometimes the anesthetists who are got that charisma, and sometimes senior GPs with more skills can do that as well. And there'll be a paramedic who will be mostly intensive care paramedics. So that's the medical skills we have. Most of all that, we need to have that soft skills, what we're talking about, the leadership skills, to make a decision under real pressure in a conditions. Also, to think laterally, just think outside the box, because none of these are going to probabilize everything. So you have to think, laterally and think outside the box. So at the end of the day, you just have to take this patient safely. Equipment-wise, it's listed there. We carry a lot of things: analgesia, RSI group, drugs, IV fluids, drugs. We carry the red taxes. The ELP is the latest addition. We carry that. That's the extended life plasma, which has got about. Usually, if you do that, it will stay outside the fridge of the blood bank environment for a week. And they say it consists of about 80% of clotting factors. We do use them regularly nowadays. We carry two of each. Antibiotics, all the rest of it. And the monitor-wise, equipment-wise, we carry all those things. Lots of things. So usually this is how the pack that just gets through. Usually you have 2 bags. Shouldn't exceed 25 kilograms. That's how the training is programmed. So one bag will have the red backpack will have the drugs. That's the suction kit, all the testing kits and all those things. The blue bag will have air kit, the McGrath blades, all the things you need for that. And you'll have a pipette, which is there right there, which will have your medication, urgent medications. And on the extreme, that's your ventilator with the oxygen cylinder, which is more electrically based. You don't need oxygen for that ventilator function. So more equipment. So if you can see on that, that's how it's configured on the ambulance, and this is how it's configured in the chopper. So we use the A139 retrieval nowadays. It's a countrywide thing. One thing is, if you can see, it's very congested environment. So if you think you can do anything in the ambulance or in the chopper, forget it. It doesn't happen. So you need to make sure nothing goes wrong before you set up the patient. And if you think, oh, I can deal with that and this, it's never happened. It's very hard to do that. In the chopper, with the noise you have, in the ambulance, with all the turbulence you have, it's very hard. We usually have protocols, so it's all protocol driven. So there's lots of protocols. I don't want to go into that. These are all some many popular protocols we have. I'll just go with a clinical scenario. So this is a case study example. So you've got a 45-year-old man who is fallen off his bike at high speed. He was wearing a helmet, his GCS score. Look at him, his stats are 70 on road man, got some oxygen, so he's given tachycardic, hypoxic. And most of all, it's right in the middle of the tunnel where the chopper couldn't land. So you have to winch down to get this patient. So that's where we're there, winch down. Now, issues at the scene, same as we expected as your scenario was. Airway, he needs airway support, but it's open with returns. Don't worry, you're worried, but not the urgent thing. Such a good breathing, 80%. Got to reduce airway, and if you're on the left side, need further assessment. That's there. It's obviously he has got blue IV access. He's in a terrible state of shock. And that's his GCS. He is having a close injury, plus a spinal injury, plus or minus a shock. So this is the scenario sometimes we expect there. So you said you're going to take the EE to the scenario. There you go. The aim of the game here is hypotensive resuscitation. You expect to try and maintain a blood pressure of 80. You don't want to fill up too much, and it's on a leading tap. So that's the aim. So in this case, it's always a stay play. So what we did was, cannula, because to get a cannula, it was shut down. So intraosseous is a good thing. That's your fast. So we always carry that little ultrasound machine. That's our friend now. All the clinical assessment we literally do is by ultrasound. Ultrasound does most of the stuff. So it's not a bad thing to learn. It's very helpful. It answers most of the clinical questions. So we do that really internally. All right, for hemorrhage control, I thought that's the first thing to do. C, instead of A to C way, you just have to stop this. A is breathing, B is consent, C is the issue first. So I want to manage that. So pelvic binder, we don't know, it could be an open pelvic injury, so pelvic binder. First, tranexamic acid. We give calcium gluconate some arbitrarily because we know a lot of clotting factors need calcium, so we just give it. Fluid resuscitation, as I said, Paxil, some of the first line things. And we also can give extended life plasma. So the aim of the game is again is hypotensive resuscitation. You don't want to fill up too many things and more small bleeding. That's the idea. That's next step is that's a lung ultrasound. It's supposed to be a video, so there you go. So that's the lung ultrasound. At the scene, you know that there's no air. So that's pneumothorax, potential detention. So what we do is we do, let's say, finger thoracostomy first. That's the first thing. And then, if you've got time, then you go in followed by an ICU. Mind you, any interposal, procedure at the scene, the risk of infection is high, but this patient needs to survive to come to that stage. Reassess, this is what we've got. Then A, now we're coming to A comes to the spinal cord precaution as well. Cervical collars, it used to be hard collar always. There's no real evidence to say soft collar is inferior to hard collar. We now have gone back to the soft collar. This is GCS4, so this guy is not going to maintain his airway, so he needs intubation. Then potential cause head injury. Again, we need to, the main aim is to prevent secondary brain insult. So you don't want to have hypoxia, you want to avoid hypoxia. Remember we were talking about hypotensive resuscitation with a bleeding patient. Again, the aim, we have to set the goal a bit high. Because if you go for hypotension, you're going to lose your brain perfusion. So now we have to change parameters. Maybe I'll aim for Sicilian 100. But in saline, we've got there's no harm in giving that one. And this is what I prepare for transport. Always say, these are all things which can happen during transport. Just be aware of them. Lastly, have a good way of handing over. A good handover makes life a lot easier. This is what we do. It's what we do, but we do whatever system it works. Thank you.